So I think what we will do now, I'm going to just quickly go through my slides. There is a mic. Do you want me to shout? No. Okay, great. So I think one of the things that we learned from renal denervation therapy, that patient selection is one of the important keys. Hypertension, or HN3, has really taught us that patient selection is important and how you do, in addition to the patient compliance and preference. I think one of the major things that made us all sit in this room, that hypertension is a real problem. It's a problem for all of us in this room, but it's a major, bigger problem to the general global healthcare. So, and I say we did not give hypertension as a disease its own prestige. We have created a diabetes clinic, but we did not create a hypertension clinic in each hospital. So there is no dedicated team who have experience in hypertension and hypertension management. And that's for what? For the second cause of renal failure, for a disease that will be the second cause of renal failure, the first cause of LVH and heart failure, and you have this all arrhythmias, including atrial fibrillation. So hypertension is a major global problem. And if you look at distribution, it's a disease of all people, rich and poor. It's not really confined to a certain population. So it is a major global problem with a huge prevalence. The interesting thing is that 44% of this is patient in trials, okay, were partially non-adherent to their medication. So it's very important that when patients come to me, and she's an old lady or a young man with multiple medication, has diabetes, dyslipidemia, and I said, "You're taking your medication?" And he said, "Yes." I said, "Okay, can you show me your medication?" And I always instruct my patient, when you come to my clinic, bring your bag of medication. And I'll tell him, "Okay, show me how you take it." And it's not uncommon, it's actually very common. You will discover that they have decided to ignore one of the hypertension medication because it's causing them lower lymphedema, or it's making them go too frequent to the bathroom. So they have decided to ignore it. And you think they are compliant. They are actually partially non-adherent to their medication. So it's a very common problem. Of course, when you look at who's the worst adherent, male come in the front. We are naturally ignorant. We don't like to take care of ourselves. We like people to look after us. So this is male. Younger age, of course. The younger, the more he think, "Oh, I'm going to take medication for how long?" And well, I'm fine. I feel okay. And then, of course, as the number of medication goes up, the number of medication taken goes less. Of course, diuretics is the commonest medication to be ignored because, you know what, we have a meeting today and I have high blood pressure. I'm not going to take my diuretic this morning, okay, because I'm not going to go to the bathroom. When you look at the spiral hypertension on MED trial, it's very interesting how the patient adherence who are adherent at the beginning become non-adherent, and the opposite. So there is a huge variability, and this is why you need always to emphasize on patients about their adherence to medication. And these are the patients sometimes you need to make them more or less resistant hypertensive. And this is where maybe you have to think of renal denervation, because this is how you're going to make this. If you have somebody who has a very tough head, you need really that head to be softer so you can manage and talk to him on the future. So the way I see that there is a problem with this patient. Predictor of non-adherence, of course, the younger the age, men are more than the ladies, and the number of medication, as we mentioned earlier. The good thing we know, if you or of the patient is adherent to his medication, we know that this translates into a real reduction in cardiovascular event. We know that minimum reduction in blood pressure, a 2 millimeter reduction in blood pressure resulted in 10 millimeter reduction, 10% reduction in cardiovascular, combined cardiovascular, and 27% reduction in stroke. This is a very important factor that as you make blood pressure more controllable, even if it is not the greatest number that you want to see, it's not 120, but he was 180, and this is my patients. He was 180 in his village, and he's coming with a reading 170, 180. Now he sent me on the WhatsApp, his blood pressure is 140, 135 after renal denervation of 6, 8 months. I say you're doing great because you're 180 on 6 medication, now 140 on 3 or 4 medications. So he's having less side effects and he's having less what we call end result vascular event. So you have a risk reduction of coronary artery disease by 10%, relative risk reduction of cerebrovascular disease by 22%. So that's very dramatic. Adherence, of course, the non-adherence to the antihypertensive is a widespread problem, but this is a very interesting slide because this was a surprise for me. People are willing to die 2 years earlier than taking 1 tablet of hypertension. So you have 30% of adults would rather die early, 2 years early, than taking 1 tablet a day. I couldn't believe it. So if you go into the thing, it's 8.2% of adults would give up 2 years of their life to avoid adding 1 daily pill. When you go into the trials, and this is the German registry, before starting therapy, this patient not taking antihypertensive medication, 38% were willing to actually give up the medication and not take medication. They rather go for renal denervation rather than going into taking 1 medication. When they start taking medication, this percentage goes to 28%. So, which kind of hypertensive patients are best suited for the renal denervation? Those who are not controlled despite drug therapy. And in the OnMed trial, which is 3 medications, shows that this is moderate hypertension patients. They're actually showing a positive effect. This is the OnMed trial. The OffMed trial is the patient who actually prefer renal denervation. Okay, in spite of this, they has a positive effect at a small number. So we need a larger trial. We need a contribution. We need a bigger registries. Dr. Al-Habib is here, so this is an opportunity for a bigger registry in Saudi Arabia. I think those who are intolerant to medication, this is very common. Patient beta blocker, male doesn't like the beta blocker. They don't like diuretics. They feeling a lot of peripheral edema with ladies. She doesn't like how her foot and her ankles look because of the amlodipine. So they don't like medication, and they're not tolerant to medication. So these are the patients that actually we should consider. What other factors we should also consider? The patient who's non-adherent to their medical therapy, which is a lot. We say at least 44%. Other with comorbidities because they have a high cardiovascular event at the end of the road. The age, younger age, are better responder than older age, but both should be considered. Cardiovascular risk, patient with different characteristics, like the one who's in the RCTs, and the neurogenic, what we call the white coat hypertension. I'm going to go through cases, and you have the green and the red in your hand. If you agree that this patient should go for renal denervation, or would you consider this patient, you'll go with green, and if you say no, it's red. Okay, so this is a 58 years old female, hypertension for 7 years, diabetes, dyslipidemia, and atrial fibrillation. 3 antihypertensive drugs. She had the side effects with many antihypertensive drugs. Her ambulatory blood pressure, not office, ambulatory blood pressure is 152/96. Would you consider this patient for renal denervation? I have 1, 2, I have a lot of green. 1 red. Why not? I think why not is very important.
Mohammad, I have to remind you after 5 minutes,
Yeah. Okay, we're going to move quickly.
Patient is not tolerant to the medication, so he will most likely will not tolerant to all the medication. So any solution is irrelevant.
So you rather, it's an all or none phenomena in your book. Either he will have severe hypertension and have all the complication, or I should actually not offer him renal denervation. Or I should offer him renal denervation and he should be tolerant to medication.
The patient is not tolerant to medication.
So he's a good candidate for renal denervation. Yeah. So it's yes. All right. So based on the literature that we have, can we move with the slide, please? The slide is not moving. Okay. So we have the randomized sham control trial. This patient, of course, we have the 24 hours blood pressure monitoring pre and post, and there is a clear reduction in the blood pressure. In the real world registry, the resistant hypertension patient, diabetes and atrial fibrillation, there was also a significant reduction comparing procedures versus none. And if you look at atrial fibrillation, there's lots of actually small registries and case series, but this is maybe the biggest. We're showing that there is a real reduction in atrial fibrillation and a better control by the number needed to treat is 3.5 to prevent one event. So as more cardiovascular adverse side effect or cardiovascular risk is present, I need to move quickly. So I'm going to go to the next case. So this is a high-risk patient that should be offered renal denervation. Next patient is a 58 years old female. This is the same. This is the same. 46 years old female. 46 newly diagnosed hypertension. Ambulatory blood pressure is 140 over 96. Would you give her renal denervation? She's newly diagnosed, 46. Majority says no. Okay, so if you look at the blood pressure reduction in absence of medication, this is the off med. And this is where we think the future is, where patient can choose in her therapy. She had a preference. Okay, because the one that she does not like medication, she's not going to take the medication in the majority of her time, because you cannot force her to take medication. There's a couple of studies. We have the renal denervation and we have the ultrasound system. Both has been showing a positive reduction in control. You have this 7 to 10 millimeter reduction, which means almost one tablet of medication. So that's make life easier. I'm going to jump to the renal denervation. This is some of the guidelines in Taiwan Society of Cardiology and the Italian Society. They're trying to come with the real guidelines. We hope after the American College and the publication of the trial, I think that's going to change some of our guidelines, and we expect that there is a consensus statement of 3. There's a consensus statement coming. Yeah, next month. Yes, the consensus from the group for looking at the medical devices for hypertension.